Work Wellness Institute is transforming research into workplace performance and health. As an organization, we function throughout the complete cycle of turning research into practice, mobilizing knowledge as a research institute, community partner, funder, and educational provider. Our mission of creating safe, healthy, and inclusive workplaces for all is our driving motivation. Learning is a lifelong journey to adapt to the forever changing needs of the workplace. Whether you are a leader, a professional, an academic, or a student, we provide high-quality resources that are evidence-based, topical, and relevant to all industries. Choose the Work Wellness Institute as your learning journey partner and become a member to gain full access to our diverse knowledge mobilization programming, including lectures on demand, e-curriculum, 3 distinct certification opportunities, and more. Continue to learn and connect with the Work Wellness Institute and see how we can support transforming research into performance and health for your workplace.
Okay, wonderful. Well, an official welcome, everyone, and thank you so much for taking time out of your day to join us in today's webinar on sustainable workability and long COVID. My name is Elizabeth White, and I am the team lead of learning and development with the Work Wellness Institute, and I'll be helping to host and moderate today's webinar. I would like to start by acknowledging I have the privilege to live and work on the traditional, ancestral, and unceded territory of the Coast Salish peoples, Squamish, Tsleil-Waututh, and Musqueam nations. This webinar is made possible through the support of our funders, partners, as well as memberships to the Work Wellness Institute, and we thank our advisory committee and speakers who contribute to this webinar series. Okay, well, thank you so much for indulging in those housekeeping and kind of technical things right off the hop. And I am very pleased to move right into today's event and introduce our speaker today, who we're very excited to have, Dr. Jennifer Lunt. She is a qualified health psychologist with 20 years of experience of application health psychology to research, training, and consultancy within multiple industry sectors. She's a program leader for the Master of Science in Behavior Change in the University of Derby, formerly principal health psychologist at the Health and Safety Executive, with research interests and publications in well-being at work and sustainability. So we're so pleased to have you here today. Thank you so much for joining us, and I'm happy to pass things over to you now.
Thank you ever so much, Elizabeth. And firstly, hello to everyone. It's a pleasure to be here. And I would like to thank the Work Wellness Institute for inviting me and providing me this opportunity to share some of the learning from my research in the area of sustainability, sustainable workability and long COVID. So as Elizabeth has just indicated, I'm a health psychologist by background, and I have spent several years in applying health psychology to workplace well-being and health and safety. And in that time, one of the main area of need that has become apparent is the need for workplaces to better able support people who have long-term health conditions, especially as they get older. And that's necessary in order to avoid sickness absence, and necessary to maintain productivity and skills loss from people who would otherwise who still have something to offer the workplace. So this is an area. So when long COVID sort of emerged as an area of need during the pandemic, it provided a platform which really emphasized that need to understand what can be done to keep people working where they do develop long-term conditions, especially where they are of an unpredictable nature, such as long COVID. So what I want to do with this presentation is I'm just going to try and go into the next screen. It was working earlier on. Right, so what I want to do with this research is to draw out understanding or deepen everyone's insights in what are the enablers and obstacles that affect people who have long COVID, that can affect the workability of people that have long COVID and affect their ability to sustainably return to work. And I do that through the lens as a health psychologist of a biopsychosocial approach, on the premise that understanding the interplay between individual factors such as a person's physiology, their biology, and how that interacts with psychology, and also how that in turn interacts with their work context and a wider context, if you like, outside work, how that provides a framework for organizing and providing a robust, comprehensive understanding of what needs to be addressed in order to make staying at work and staying effective a realistic outcome for people who have conditions such as long COVID. So just to emphasize, this is very much steeped in a biopsychosocial approach, and certainly in the last 20 years or so, the utility of the biopsychosocial approach in terms of understanding health conditions and occupational health conditions has gained ground and has gained prominence, has been able to explain symptoms that aren't necessarily uniquely predicted by the medical model because of the understanding of the role of psychology and how we respond and how we cope with conditions. And secondly, what I want to do as part of this is also to draw out the findings that inform what are the kind of working conditions, the contextual conditions in the workplace and the support around that allows people with long COVID to return to work and to stay back at work, and also what self-management they can do in what support needs to be provided in the workplace for them to be able to self-manage their symptoms alongside work demands in an adaptive way. So I'll be looking at feedback from people who have workers who've had long COVID on what the workplace accommodations to self-management strategies are. And as I said, I really want to emphasize the utility of the biopsychosocial approach as a mechanism by which to really develop a reliable understanding of this area. Okay, so I hope that's sounding clear. So in terms of just some terms of reference, so most people have an understanding now of what long COVID is. I have here the WHO definition of long COVID. In the UK, there's also a NICE definition as well. But essentially, it's a condition, i.e. a syndrome, that is linked in some way to COVID infection and is protracted symptoms. Often the symptoms associated with long COVID aren't necessarily proportionate to the symptoms that were experienced in the acute phase of COVID infection. There is more growing, I mean, that is now understood, that because even if people have mild acute symptoms associated with COVID, they can still develop long COVID, and the impact that it has on that can have on functioning can still be fairly profound. Okay, so there isn't a proportionate relationship between the acute infection and the chronic, the long COVID that ultimately develops. In terms of this research, when I first started on research, long COVID wasn't really known as a condition. It emerged over time. And what it meant that over time, more people have been formally diagnosed with long COVID, but there are also people out there who think they've had long COVID, but they've not necessarily have had an actual diagnosis. And that might probably still the case now. So it's useful to bear in mind long COVID can be suspected or confirmed, and it's useful to talk to both groups of people. And also when I talk about workability, it does what it says on the tin. What workability means is essentially how long COVID affects our ability to work. And often that's operationalized as being about psychological workability, so how the cognitive impact on long COVID affects our ability to carry out our usual workload, and also physical workability, so how we contend, how well we can contend with the physical demands of the job. And often, for example, with long COVID, it is possible for people to keep on working, where, as I found in the later research, where maybe they don't have the same physical demands, but they do have they can still keep working where they don't have physical demands, but they still have a relatively psychological demands going on as well. So yeah, workability is best understood through the lens of both physical and psychological workability. Okay, I hope this is all clear. So there's two main pieces of work that this presentation is drawing on. There's a study that's published in 2 papers that we undertook. So I just want to acknowledge my colleagues in this. So Sally Hemming, Dr. Sally Hemming, who is a human resource expert, Professor James Alander, who's a fellow health psychologist here at University of Derby, Amy Baranek, who is also health psychology here at Derby, Professor Kim Burton, who is based at the University of Huddersfield, who informs our Department of Work and Pensions on health at work issues, and a student that worked with us in this first project, Denise Ellington. And then, so that's the first study. So the data collection for that first study occurred way back in the first winter of the COVID pandemic. So we're talking actually 2020-21. That data collection occurred there. So the area of long COVID as a condition, was the understanding of it was very much emerging at that time. And then more recently, we've done some more in-depth qualitative work with individuals who have made some kind of attempt to return to work in some way with long COVID. And we did the data collection for that in the spring of this year. So that's fairly hot off the press, that kind of evidence from that. So what we did with the first study, on the premise that we could see there was emerging evidence that the effect that COVID was affecting our functionality, our physical and psychological functioning, I wanted to find out fairly quickly what workers who were affected, what their views were on what kind of support they needed in order to either stay at work or get back into the workplace. And that was using very much a mixed methods design, an online survey. And then in the second study, so the emphasis on that was more on what they thought they would need to get back to work. So what they anticipated they might need to get back to work, based on their experiences at that point. And the second study was really more recent, and has been about tapping into the actual lived experiences of people who have had long COVID, but in order to tap out really what has worked and what hasn't worked in terms of being able to work with long COVID. So there's 2 studies in there with 12 months, approximately 2 years between them. That's kind of explored this whole area around the enablers and barriers to workability for people who have long COVID. Okay. And so the first 2 are published. The second 2 is undergoing submission at the moment. The second one is undergoing submission at the moment. Okay, so just to tease out what the sample was for the first sample. So this was our exploratory sample. It was mixed methods, so we got quantitative and qualitative data back, and our sample comprised 145 UK workers. Most of them were from the health, social care, and education sectors. Most of them, over 70%, had been classified as what was called in the pandemic in the UK, certainly, as essential workers who had to who could not work from home, who had to keep going out and working. So most of those in that first sample were essential workers. And most of them at that time were reporting a detrimental effect of their post-COVID symptoms upon their ability to work. In that the most they were experiencing was a moderate level of workability. So we use qualitative data and content analysis to understand what the enablers and barriers were, but also we did some kind of run some inferential statistics to explore the relationship between their health status, such as severity of symptoms or symptom duration, and the reported workability levels in that study. And then in this more recent qualitative piece, our sample comprises 11 workers. Well, we've undertaken more of a deep dive analysis into their experiences to get their views on what has and has not worked in long COVID. And these are people who have made some attempt to return to work. And as we found, the majority of them were working in some way. Some of it perhaps in a more limited way than they were previously, but they were certainly working. And there was there's another one who'd made several attempts to return to work, but was still struggling, so it was classified as still off sick. Okay, so those are the two studies, just to emphasize that. And again, this is all underpinned by the biopsychosocial model. So just to carry on, so for this next section of this presentation, what I'm going to draw out is some of the evidence around the impact of long COVID on workability and on worklessness, which underscores why this is an important area for us to develop effective interventions in order to keep people with long COVID usefully contributing to the workplace, given the number of people that have been affected. So this section is emphasizing why it's important, and also I'll be covering some of the symptoms as well. So just to underscore why this area is important. Okay, so we're over 3 years since the outbreak of the pandemic now, but there are still a huge number of people around there certainly in the UK, in Europe, across the globe, who have long COVID or is estimated as having long COVID. Something like recent estimates across the globe is 65 million individuals worldwide are estimated as having long COVID, with cases increasing daily. And in the UK, certainly there's around 2 million people reported as having long COVID at the beginning of this year, according to our Office of National Statistics, ONS, of whom 77% reported that it was affecting their ability to undertake their daily tasks. And then again, there's been recent surveys in the UK, some more kind of quantitative evidence by a trade union organisation, TUC, saying, for example, that 14% of workers in a survey of 3,000 UK workers reported losing their jobs, 66% reported unfair treatment, and 48% reported that adjustments had not been taken. So it's not only the case that people with long COVID are experiencing challenges getting back into the workplace, there's now evidence that they're not getting the support that they necessarily receive. In the US, something like 4 million workers have long COVID. And in the UK, there is more recent evidence. There's a challenge around growing worklessness amongst the over 50 years age group, who there's a lot of people in that age group who are economically inactive, who have chosen, either because of the pandemic, but since the pandemic, disproportionately more amongst that population, have chosen to no longer continue working, to take early retirement. There is evidence around that. And long COVID in some places has been attributed as one of the reasons. But there is certainly, it's compounding the challenges in the UK around productivity, around around how we support an aging population with fewer people actively economically active. So that kind of heightens the need for really understanding what can workplaces do to support people who have long COVID and related conditions. For tackling some contemporary economic challenges in particular, and the wellbeing challenges as well, of course. Okay, so just to emphasize what long COVID symptoms are, there's more, right, the extent to which underlying pathology is affected varies, of course, between individuals. There's more evidence that people coming back to workplace do have had a profound pathological effect that's been attributed to long COVID. But the most common symptoms of long COVID is typically fatigue, respiratory problems, and in particular cognitive impairment. But what became really apparent, especially in the conversations we were having with people who've got long COVID, is really how multi-system the symptoms are, how many physiological systems are involved in long COVID potentially, but also how eclectic it was. And for example, that there were people who despite experiencing a lot of fatigue, were still able to carry out a sedentary job. And there were other people who reported a detrimental effect on their cognitive workability, but who were, for example, still able to cycle to work. So it's not, this didn't seem to be, and this is from the qualitative research, so it's not necessarily in terms of its generalizability to wider populations. It's not that kind of evidence that does that, but it's showing how eclectic people's experiences of long COVID are. And therefore how the support that they need needs to be really person-centered, which is where the biopsychosocial approach is particularly useful because it affords a person-centered approach. So again, there's these typical symptoms that are associated with long COVID, and you can see, particularly the ones around fatigue and cognitive impairment, how that can have a direct impact on the person's workability, physical and psychological workability. Okay. So having explained why this is important and emphasized, and I think the reason why everyone's on here, because they know it's important, but what the challenges that are posed by conditions such as long COVID, and in terms of people's well-being at an individual level and employer kind of productivity, but also global productivity, if you like. What I'll do is in this next section is unpack a bit more what are the workability obstacles and enablers that we found. And I've separated them out according to a biopsychosocial model of rehabilitation. So i.e. namely at the individual level, at the level of the job, meaning the person's immediate work environment in terms of the context they're working in terms of the kind of quality of support they're getting, the management support they're getting, and also in terms of a wider organizational context, as well as the external context. So really unpeeling these enablers and barriers according to that onion of influences, if you like. So in terms of what we found from the first study, the exploratory research, is that, and bearing in mind this was done about 2 years ago, is that there was a statistically significant relationship between symptom duration, not symptom severity, or the severity of symptoms when people first contracted COVID, but there was a significant relationship between symptom duration and physical and workability ratings, which is interesting. That's an interesting finding. So that's kind of testifying to some of the challenges around what's emerged with long COVID. And secondly, so that's a kind of the quantitative findings. In terms of the content analysis that we did, What I've done here is I've indicated for each of the main areas of the biopsychosocial framework for vocational rehabilitation what the leading obstacles are in this case. So of course, as you would expect, fatigue was, and a need for a huge amount of rest was a widely reported obstacle. And at that time, some of our respondents were concerned about being able to maintain social distancing at work, bearing in mind this is when the pandemic was still very much up and running. So not able to social distance, and bearing in mind our sample comprised a lot of healthcare workers with patients. Also poor concentration, so was of course a big obstacle, especially for metacognitive tasks, such as running a meeting or chairing a meeting, for example, or teaching, or where we're having to think across a range of different issues in a moment. Metacognitive tasks in particular seem to be affected. The unpredictable relapsing nature of the symptoms, of course, is an obstacle, which made it very impossible for people to plan how to do work. Also, the impact, the safety aspects of working with, especially with in patient interactions in this case, or client interactions where there's patient safety implications, the safety aspects of concerns over that was reported as an obstacle from our respondents. And also there is a sort of bunch of feedback around relating to professional identity. So people feeling that they would not be able to fulfill the expectations that would be expected of them as their professional in their role. So obstacles around their perceptions of their professional identity and being able to uphold that professional identity was highlighted. And also another important thing to bear in mind is that the effect of long COVID or post-COVID symptoms on workability is very much dependent on the nature of the job that the person has. So the interaction between the symptoms and how physically or psychologically demanding their jobs were, especially with nursing, being on their feet all day versus more sedentary work where there wasn't that so much of an issue. So again, this is a really important point, I think, is that understanding the impact of workability very much stands to reason, depends on the nature of the work that the person has. And might mean that some people changing jobs or changing career or going to a situation where they have more control of the demands they're placed under might be more of a suitable avenue by which to support their workability once all other options are explored. Also, ability to control their control over the job pressures was another obstacle. And again, that was borne out in the more recent qualitative research that we've done, more case study based research that we've done. The working patterns that people had the flexibility around that, but fixed working patterns could be an obstacle in some instances. And also symptom interaction with cognitive demands of a job, in particular brain fog. So that's the kind of job obstacles. At the work support obstacles, what we found was some sort of inconsistent reporting around the quality of the occupational health support that people were getting and human resource support that people were getting. So some people simply didn't have access to occupational health support, and the kind of sickness and this is coming through later on, but the kind of financial security that's often controlled and managed by HR, the perceptions around that, the concerns and anxiety that generated could be an obstacle for some people. Line management support, within that first sample, we had mixed evidence on line management support, but certainly where line management had the expectation that once somebody's back at work, they're fully back to work, or assuming that people were were winging it in some way. Some people reported that as their experience, and also the response of their colleagues. So especially in healthcare work, where their colleagues have been having to cover for them in some way, it kind of highlighted how any kind of return to work support isn't just about the support that the individual needs, but it's also managing the experience and the perceptions of their colleagues as well is important too. And going on to at the kind of more organizational level, sickness absence policies, the rigidity of those emerged as a quite common barrier. The extent to which they kind of recognise the unique characteristics of long COVID. At that time in the UK, we had a furlough scheme, and not all employers wanted to use furlough schemes. So furlough scheme, whereas the government was essentially paying people's salaries in lots of occupations. And also that emerged as a barrier, and the culture of the organisation, the shared attitudes and beliefs about long COVID and about the impact of the tiredness and fatigue that had on people's the attitudes to others, whether that was actually what people thought or whether people perceive they might feel that came through as a strong obstacle as well. So that kind of gives rise to the importance of generic long COVID awareness programs as part of its strategies for creating conditions that makes it easier for people to return to work. Also, as part of that, tackling some kind of assumptions that once a person's back at work, it must mean they're fully well, or you have to be fully fit in order to work. If really we want to get people back into work sooner, and generally in the area of working with long-term conditions, then I would say there needs to be, in the evidence that the research I've done in areas indicates that it's important for people to develop more adaptive beliefs about the connection between being able to work and their health, in that it's, even if you're not 100% fit, you can still do something useful, and even providing it's fair and it's reasonably done. And that period, going through that period, might be necessary for a person to regain their usual levels of working more rapidly than if they were to stay off sick, for example. Job security emerged as another barrier. And in the UK, being able to access suitable healthcare, at that time, GP understanding of the post-COVID kind of symptoms was emerged as a barrier, and also transport for getting to work. So ranging from the length of the commute, whether people using public transport or not, versus how far the car park was from their place of work, how far they had to walk before they get in the building, for example. All those are different facets of how transport issues emerged as an obstacle. So if I go on to what the enablers were that came through in that initial work, that this is based on directly on what the the workers in our samples told us, is enablers was scope to self-manage the symptoms alongside work demands. So, for example, being able to have chance to take medication as prescribed, being able to ask for help in a situation, also self-management, people's knowing their own limits of their conditions or learning about what are their limits as they went along. That was highlighted as important. Also, as part of self-management, we'll come through to this later on, it's kind of tied in with self-management, scope to pace their work, being able to make that pacing independent of symptoms, having space as chance to take breaks and space somewhere they can go to rest, have a room or something like that they could go and rest. That was described as an enabler. Similarly, and this is really borne out in our later qualitative research as well, is really the importance of flexible working arrangements, being able to, and the effect that has on people's autonomy and control. That was highlighted as important as well. Flexible working arrangements, being able to leave earlier, have later starts, having reduced hours, being able to do short periods of work when and well. So flexible working arrangements was a key enabler from that first research. As was, for example, improved line management competencies, the support, quality of support, instrumental and emotional support was described as important in that sample. The extent to which their line management kept in contact with them whilst they were off sick, I mean, that's recognised as an enabler within the kind of vocational rehabilitation research. And really graded return to work, gradual return to work was highlighted as important. And this in particular, people's experience around this in our later qualitative research really brought home how graded that needs to be. So other enablers around changing the nature of the job's task and responsibility, especially if somebody's doing a complex job or they're interacting with patients, for example, deferring that point in which they do the more complex work or the more safety critical work after they've got used to being back at work was highlighted as important. Job sharing, for example, was described as important too. Having access to occupational health and healthcare access, again, that comes through in our later research is pretty critical for people being able to regain their workability. And managing peer expectations was cited as we were talking about earlier on, cited as described as an enabler. And again, sickness absence policy modifications. So making it sickness absence policies, making sure they're accessible, making sure they're usable, the language is usable, making sure that it provides reassurance over the financial implications, and making sure it's accessible, not just sickness absence policy, but all the kind of policies that might be relevant to long COVID. That was highlighted as an enabler, and that came through in qualitative research as well. Again, as an enabler, on the flip side of what I'm saying is culture is a barrier, more realistic awareness about the nature of long COVID conditions, but also recognition that it is still possible to, there is a return on investment for getting people back to work with long COVID in time and providing them that support. That's recognised as important too. Which is linked to that kind of wider positive attitudes, collective attitudes about workability and health at work generally. So this is what we found that's what we found in the first study. In the second study, so this is this more in-depth exploration of people's lived experiences 2 years on, their interpretation of what has helped and hasn't helped in terms of getting them back to work. And as I said, most of the people that volunteered for this study, so it's a small qualitative sample, were working in some way. And we asked them more through hour-long interviews what their perceptions were of what helped and didn't help. And what I'm doing with these slides now, a lot of these findings mirror what we found in the earlier stage, but what really came through at the individual level was the fact that people's experience of long COVID was, or the impact of long COVID on their ability to work, ebbed and flowed over a long period of times. And they might have spells where it gets worse, they might have spells where it improves, they might contract other conditions, they might develop conditions secondary to long COVID, they might contract long COVID again, that worsens the situation, or they might contract another virus that worsens the condition. So any approach to keeping people in work with long COVID maybe needs to recognise the uneven nature of the symptom journey and how that might pan out over time. But even despite that, it's still they could still provide something useful in the workplace, especially in this case where we had lots of professionals who responded to this qualitative study to keep their valued skill sets in the workplace. And linked to that as well, another enabler that came from a second piece of work was having a professional role. Okay, it's qualitative, and most of the people that responded to this in our sample were professionals. But what came through is that the leverage of being a professional, in terms of that they would be hard to replace, almost gives them slightly more negotiatory power as being an asset to the workplace, which means that they have more to draw on, more to negotiate with in terms of their employer. So being a professional, from this small qualitative study emerged as a kind of enabler. Another part of that, linked to that as well, being professional, was many of the people that we interviewed were in positions where they could afford private healthcare. So the rapid healthcare access that gave them via their jobs, that diagnosis of any other underlying health conditions that might be linked to long COVID, such as, I remember one particular participant was talking about how seeking out help for long COVID meant that the underlying conditions related to obesity, for example, and hypertension, that was diagnosed. Getting that opportunity because they had access to private healthcare meant they were able to recover, from their point of view, more rapidly. So access to private healthcare was highlighted as an enabler. Also, linked to autonomy and being a professional, if you like, is having more discretion over when you work and how came across as an enabler, and meant that for people who were professionals in our samples, a couple of them had recognised that they would have more control over managing their symptoms and their demands of a job by becoming self-employed. And the reputation that they had offered up until that point meant that they had a client base by which they could get income for being self-employed. So again, that kind of becoming self-employed for some of our sample was a solution they had for being able to carry on working in a way that helped them to manage their health condition.
Sorry, just to interrupt, just in a few minutes, we'll want to transition to Q&A.
Yes, sure. Thank you.
Thank you.
Elizabeth. Thank you. And also careful pacing emerged as an enabler as well. Micro-planning tasks, really fine-tune micro-planning. So scope for individuals to think through on an hour-by-hour basis what they were going to do to change, when they were going to have a rest in that hour, when they were going to switch tasks from something more difficult cognitively to something easier. That was emerged as a coping strategy. Again, I've talked about autonomy and how that has come through as an enabler in a second piece of work. And in particular, really fine-tuned phased return. Our participants were calling for this really incremental phased return process and planning and support that they would be co-produced, that takes into account the ebbs and flows of their conditions on a day-by-day basis. Really iterative, fine-tuned phased return. They said that if they had that kind of support, they would be better able to keep on working. And then another interesting finding, virtual working, of course, so working in sedentary work was in this instance, in this research came through as an enabler. Whether that's sustainable over time, constantly doing sedentary work and what the implications that has for physical fitness, maybe that's something that needs to be explored. But another obstacle that came through for some people, what they experienced was performance management. So because the symptoms meant that they weren't kind of firing on all cylinders, they had in a few instances been put into performance management, which ironically compromised the performance still further because the pressure that generated exacerbated their symptoms. So again, this highlights the need for a very much a person-centered approach. Similarly, coming through in this qualitative work was a timely access to healthcare, and that was cited as important, being recognised as still as a valued skill set and organisational support, being open about their conditions. Some of our samples described that as an enabler because it was helpful in terms of managing expectations. It probably meant that they worked in a culture that supported that, and also having colleagues that could step in and cover for them emerged as an enabler that wasn't necessarily there in the first research. And finally, something else that's emerged is now, some of them were describing was, for example, from colleagues who've got over COVID, being less sympathetic towards them on the basis that I've got over this, why can't you? So that's coming through for some as an obstacle as well. So what are the implications for this, the workplace accommodations and self-management? Well, firstly, what the second piece of research highlighted in particular was that it is possible to work with long COVID, to get back to work with long COVID. And that happened, according to our second piece of research, where people were in a professional role, they're harder to replace. It means they can get more likely to be able to exercise discretion as well over when and where they worked, especially if they entered into self-employed work, being able to work virtually, and therefore meaning that they probably predominantly in sedentary work that emerged as a circumstances that means it's more, according to this qualitative research, that keeping working is more possible. A strong interface between the quality of healthcare support they were getting and management support, between the occupational health work professionals, how closely they're working with line management was highlighted as important. And having access to policies that generally steers an approach to managing person-centered approach on the basis of their need, rather than on equity, as one of our participants said, rather than just equality. So not just making sure that people with different conditions, because people with different conditions have different needs, it's not about, they felt it wasn't about treating everyone the same, which is based on equality. It's about making sure that it's based on equity and it's very much based on person-centered needs, as highlighted as support. And other workplace accommodations, it seems really particularly important for long-term COVID in particular, scope to self-manage, this iterative return to work planning seems really important. This kind of this fine-tuned support that they seem to need in order to keep them well, or scope for them to do that themselves, and avoidance of fixed phase return plans that says after 4 or 8 weeks that they must stay at work, they must get back to full-time work. Those kind of patterns do not seem to be helpful for people with long COVID. Support from peers, accessible person-centered sickness absence management policies, and these awareness-raising programs within organisations generally and society generally about the challenges posed by long COVID, but also challenging some of the myths around health and work that might be associated that has come through as an enabler. And in return for making those accommodations, what our participants are saying is that employers will be able to retain specialist skills. They'll be able to foster commitment within their workplace. They'll be able to get sustainable return to work for people with long-term conditions, such as long COVID. And in return for that, over time, they will get more productivity. So there's a business case, if you like, that's come through from our research for supporting people with long COVID back to work. So just as a summary, what's the key messages from this work? What our work is highlighting is that it is possible for people under certain circumstances, and maybe there's some degree of privilege in this, in being able to work in that, where, for example, where they are professionals, there are circumstances where it is possible for people to get back to work. But what's really necessarily is this really fine-tuned, iterative, co-produced return to work planning and support seems key. This person-centered approach to health at work and generally seems key, and that mirrored in policies and so on. And in return for that, employers will benefit from skill set retention, sustain the diversity of their workforce, look after their reputation, and also mean that society can, in general, tackle challenges associated with growing worklessness and economic inactivity amongst aging populations. That's certainly apparent within the UK. And also, the final thing is there is a bias, a bit of selection bias in our research, in that the people who tended to respond to our research have been professionals, or they have been professionals, let's say, white collar workers. So where the research on this really needs to go, as well as evaluating interventions that support this, is also really trying to reach those not the blue collar workers, to find out more about what their experiences of working has been and what support they need in particular, to being able to keep productive, especially, for example, where they might be easily replaceable. What we've found is what our work has revolved around is there tend to be a focus on people who are white collar workers and tend to be harder to replace. So that's an area of research that needs looking at. And I think that is my summary of my research. So I think, Elizabeth, I'll hand it back to you for a second to take the Q&A.
Yes, thank you so much. I'm going to dive right into the question and answer, because we have some right off the top from our audience and we have a few minutes left. So I just want to get through them. So the first question that we've received is a personal experience of someone who's repeatedly had COVID, unfortunately, and each time they had it, the long COVID effects became worsened. And, often the workplace didn't quite understand that or weren't accommodating to that. So what are perhaps some strategies from like the individual level to help advocate for themselves on how they can get the employers to really understand their situation, and that, this does change or this could become worse, the episodic natures that we were talking about today?
I think, well, I mean, that is speaking to the fact that within our findings, there is that people who've got long COVID, they have this uneven symptom journey, that for some people, long COVID hasn't just, has been recurrent. They've contracted COVID over again, and that we did have one or two people, one person said, certainly, who said they'd had long COVID twice in our second sample. Right, so I've not directly had long, this is speaking from the data that we found. I think from this really flexible support that they need in return for that, if they get that flexible support, creating a case around what you can still do within, once you have that control, once you have that, having that autonomy that you need, and support and a sympathy around that. If you have those kind of conditions, then it seems to be, does seem to there is a potential return on investment for your employer. There is hope. There is hope. And that's coming through from our second sample. There is hope. In return for that initial support, you can give back. Hopefully you will be able to give back. And people with long COVID can give back. And it means that their employer has not lost them as a without sounding too functionalness, as their abilities, their skills, and their assets and their experience. And also, what some of our participants said as well is that they didn't necessarily go back to the same role, but the other ways of working, such as supporting or coaching others there's another way by which they
Right.
might not be directly useful themselves, but they could still be supportive through others. There's other
Okay.
means. So it's that flexibility again.
Yes, flexibility, creativity, really thinking through all of the solutions. The next question is, did you find that the symptoms, or within the studies and those that you spoke with, did you actually find that the gradual return to work aided in their symptoms, or was that not really a factor? It just kind of helped them maintain what they were able to do.
Oh, I mean, certainly from other because this is where it links with other kind of long-term conditions. I think from other research that we've done beforehand with HSE, for example, one of the benefits, or one of the reasons, a rationale for why working working whilst recovering from a condition should be more effective than going off sick is because it's working with your self-efficacy, it's working with your self-confidence. It's you're proving to yourself that you can do something that's useful, and it's also proving to your employer that you can still be useful whilst you're still experiencing symptoms. I think, okay, there needs to be more research to prove on that, but there is evidence on that, it's qualitative evidence on that, but that from a kind of understanding of the biopsychosocial approach, self-efficacy and a sense of, and coupled with the autonomy and discretion over when you work and how, that should mean it's more likely it's possible to get back to work.
Yeah, it's so
Or keep on
interrelated,
that.
and we've seen that in, with different illnesses and disabilities and things.
Yeah.
Absolutely. So the next question is actually around the disease prevention itself. Someone who has had long COVID, they might be nervous to go back. What if they contract it again? Those kinds of things. So just wanted to talk about I know you actually mentioned just educational awareness around long COVID and what it is and things, but is there part of the conversation for employers to provide education around how it's contracted, how it can be prevented? There still seems to be maybe a missing piece of knowledge there to, again, support those with long COVID that really certainly don't want to be contracting it again, and it could exacerbate or worsen
Yeah.
things.
Okay, this is bigger societal. I think there just generally
Yeah.
needs to be more education about what long COVID is, and and also other related long-term conditions, and the fact that you shouldn't be written off in any way. You've still got something to offer with those kind of conditions. The fact that you can still offer something with less than perfect health. That the fact, that those myths around health and work, I mean, it's an area that we've worked in previously. I'm thinking of Kim Burton in particular. There is an educational piece at the organizational level, certainly, and across the piece at societal level around health and work. Is really important, especially if most, if aging workforce is going to be certainly a challenge in the UK and in westernized country. If we're going to have a population that can support people, that can remain productive, this is an area we certainly need to look at. It's creating that momentum. It's building a momentum. It might not happen overnight, but it's building that momentum. It's sharing case studies of that it is possible, what is possible. This is what we're trying to do with this research, that it is possible to be useful with health symptoms, with long-term conditions. Yeah.
Absolutely. And keeping that conversation going and relevant.
Yeah.
It's not something that, happened 3 years ago or 2 years ago.
No.
It's still a continued conversation. And as you mentioned, it grows larger in scope to other illnesses as well. We've
And it
actually,
reads across, and most, isn't like we know, most conditions, most long-term conditions are complex. People, as they get older, they're going to carry forward several long-term conditions. People with long COVID are going to have other conditions. So I mean, this conversation needs to evolve. And this is a cause. We're all on the same cause.
yes, yeah, no,
Mission.
absolutely, absolutely. And it's so complex, and it, as you mentioned, has many branches into the world.
So so the more success stories that are shared, the more people Well, the more experiences that people share about what has and what hasn't worked, but especially the success stories about what's been possible, to work with that self-efficacy dynamic is really important. Yeah.
Yeah, absolutely. We've actually run right through to the hour in such a great conversation at the end. There's one very quick question that I'll end with, and then we'll close for today, just around the education sector. I know you mentioned in the study there was quite a bit in the professional and or healthcare. So we just have an audience member curious what percentage, if any, were actually from the educational sector.
There were certainly, I think something like 20% of our original sample were teachers. For teachers and schooling, we also had academics. There were certainly in our second sample, there were some academics in our second sample. Bearing in mind, our samples are not representative necessarily of the wider population, but yeah, teaching, we certainly got within our data, people who are teachers and people who've been academics. And those kind of findings around the kind of cognitive demands, about metacognitive tasks, running teaching sessions, teaching classes, I think that seems to be quite strongly linked with those kind of roles. So it's present within the data from people in those professions are present within our study. Yeah, maybe it needs more dedicated research. That's what you're highlighting. Yeah.
Yeah, I think maybe just out of curiosity, as again, it's one of those professions that, continue to work. I know it was virtual, but then schools opened back up and
Yeah.
things like that. And then I'll just end here talking to that whole idea of being able to return to work while still symptomatic, and asking, is there a specific case study that can be cited to provide, physicians or employers and things? And perhaps your study is what would be great, and we will be sending out the slides. I'm not sure if you have other resources that would be helpful to help those advocating for return to work.
Well, we're in the process of publishing our second piece, so maybe that could be useful. So when I say symptomatic, I mean you've got long COVID, people with long COVID symptoms. They're not symptomatic with not COVID symptomatic.
Yeah,
they got symptoms of long-term conditions.
Yeah.
So hopefully the second piece will help. The second piece of research, once we get that published, will help with that. Certainly we want to produce more individual case studies, but I think collectively as a community, we need to get those case studies out there. So more of those success stories. I think you might be able to find them online in Facebook in long COVID support groups. But yeah, I hear you that we need to get more of those studies out there. So I totally agree.
Yeah, and we'll keep in touch, and as once published or things, like, we're happy to continue sharing out resources as you have them. So thank you so much. We've run a little bit over, so thank you, Dr. Lunt, for being here and sharing your time with us and your expertise and bringing such a varied conversation to this topic. And thank you to our audience for attending as well and giving us your time today.
Continue to learn and connect with the Work Wellness Institute and see how we're transforming research into workplace performance and health at www.workwellnessinstitute.org.